Hello, my name is Dr. Heather Johnson, and I'm an occupational therapist and both an academic fieldwork coordinator and assistant professor at Rocky Mountain University of Healthcare Professions in Provo, Utah, for their Occupational Therapy Assistant to Master of Occupational Therapy Bridge program. I was invited to present at the St. Francis Annual Stroke and Trauma Symposium in Tulsa, Oklahoma in early September of 2023 to present on the latest evidence-based use of e-stim for patients following a stroke to an interdisciplinary health professional audience. This online version of the course is to serve as a resource to anyone that uses e-stim technologies and wants to use the evidence-supported e-stim procedures in practice. This content will be technical and advanced. If you do not feel comfortable following these procedures, please seek additional introductory training on physical agent modalities. Electrical stimulation is a physical agent modality that uses an electrical current to treat pain, inflammation, and increase active muscle use along with other purposes. The topics covered in this presentation today are electrophysiology, e-stim parameters, contraindications, lower extremity protocols, pelvic protocols, swallowing rehabilitation protocols, and upper extremity protocols. Let's start by going over the current understanding of a muscle electrophysiology and how electrostimulation, or e-stim, evokes a muscular response. Individuals exposed to several weeks of treatment with e-stim have specific changes that affect several physiological systems. Signals generated by each motor neuron distribute to a distinct set of muscle fibers, which together form a motor unit. Motor units are recruited in a fixed order. Muscle force is dependent on the adjusting of which motor units are recruited and at which rate. The higher rate the action potentials are generated, the faster the muscle contraction. When the activation of motor units is compromised, such as with the presence of a neurological event, like a stroke, it is possible to decrease the deficit by supplementing the activation with electrical stimulation of the muscle. Stimulation only recruits more superficial sensory and muscular responses, but when looking at surface stimulation, there are differences in electrode placement. When placing the electrodes over the middle third of the muscle, lower amplitudes of electrical current evoke a more superficial recruitment of motor units of a muscle, and at higher amplitudes evoke a deep recruitment of motor units of the muscle. However, when electrical stimulation is applied through electrodes placed over the nerve, there is no significant difference in the current required to achieve motor unit recruitment at both superficial or deep locations of the muscle. Therefore, the location of electrode placement has a significant impact on the spatial distribution of activated muscle fibers. Due to the widespread distribution of the nerve branches and large muscles that have several motor points, multiple electrodes are needed to engage more motor units in a muscle. In smaller muscles that have less intramuscular nerve branching, you may only need to place 2 electrodes, one over the motor point, which is usually the middle of the muscle, and the other electrode over the innervating nerve. At lower amplitude, also called intensities, an electrical current initially stimulates afferent axons, which evoke a spinal reflex response, which produces a muscle response, which is recruited from low-threshold motor units. Gradual increases in intensities will progressively activate motor axons to produce a direct motor response and eventually suppress the reflex completely. The sensory reflex response is greater when neuromuscular electrical stimulation is delivered over the nerve rather than over the muscle. The sensory response is necessary to evoke the motor response, as shown by studies that clients on nerve blocks with anesthetics, there was no motor response with the e-stim. So one could conclude that ideally your client shouldn't be taking medications that dull the senses before e-stim treatments like muscle relaxers. If a current is set below the motor threshold, the electrical stimulation, say a frequency of 100 Hz at a pulse width of 1 microsecond, may elicit a muscle force within 1 to 5 seconds after the stimulus and continue for 2 to 10 seconds. The sensory feedback from e-stim also reaches supraspinal centers, causing an increased response in cortical spinal pathways. NMES, neuromuscular electrical stimulation, has more global effects on cortical neurons that project to motor neurons innervating involved leg muscles than those related to engaged arm muscles. But we are going to cover the muscles and groups that have shown clinically significant improvements in the current literature: legs, hands, swallowing function, pelvic response, continence. Neuromuscular electrostimulation, NMES, global responses from other muscles in the same complex. For example, if you evoke a muscle contraction in a targeted muscle, like the quadriceps, it can also improve and increase strength in the hamstring. These instances are contraindicated for e-stim use or not effective. Clients who are going through or have gone through cardiac valve surgery, chemotherapy patients, patients with mild to moderate osteoarthritis, patients in intensive care, or the critically ill. Also, do not use e-stim on the arms and legs at the same time when expecting performance actions. You will get better arm movement and hand movement, especially with the medial and radial attachments. It hasn't been discussed if it affects the leg. Let's go over e-stim terms and parameters. Electromuscular stimulation, or EMS, can be delivered in many different ways, and types of application have different names you may come across. Russian electrostimulation, functional electrical stimulation, but they all generally refer to the same thing: using electrical pulses to activate motor units. Most applications are cutaneous, so we're going to focus on those, and the most commonly used applications in rehabilitation are NMES and TNS, otherwise known as NMES and TENS. I do have a few protocols for FES, functional electrical stimulation, so I'll get a little more in depth for that later. NMES, TENS, FES, and most e e-stims have an application across the skin using adhesive, or sometimes rubber, electrodes positioned to generate a muscle contraction. Muscle contraction can range from a small twitch to a powerful enough contraction to cause joint movement. Both TENS and NMES have similar stimulation waveforms, though both may have different set parameters. NMES typically having more control over those parameters. While both do the same thing, NMES is typically used for eliciting a motor and functional motor response, while TENS focuses more on sensory responses like treating pain. Frequency is the number of stimulation pulses that are delivered per second, measured in Hertz frequency. EMS devices will offer a frequency with a set range, 0 to 70 Hz, for example. Some devices may only offer one set level of frequency. Others offer an option to adjust the frequency in a preset range. Low frequency is 1 to 10 Hz. Medium frequency is 20 to 60 Hz. High is greater than 60 Hz. Pulse width refers to the length of time each group of pulses of stimulation is set to, measured in microseconds or milliseconds. It is common to see EMS devices offer a range between 200 and 300 microseconds. Pulse width on some devices is preset and on others can be adjusted. A low pulse width is 50 to 200 microseconds. Medium is 200 to 350 microseconds. High is 350 to 500 microseconds. Amplitude is the strength of the stimulation delivered, measured in milliamps. This parameter is always adjustable on EMS devices and often appears like a volume switch. Start low and bring up slowly every time, as what your client responds to will vary session to session. As a muscle gets stronger, it may require less amplitude to evoke the same response. It's important for the therapist to know what level of muscle contraction is desired during each session so intensity can be varied accordingly. Let's go over new evidence-based protocols. If you want to read further on any of the protocols I'm going to cover, I reference the articles here and at the reference section at the end of this presentation. These are the most recent protocols I've seen for the lower extremity. Evidence exists that AFOs and functional electrical stimulation can each improve gait speed, mobility, and dynamic balance. There is moderate evidence that they increase quality of life, walking endurance, and muscle activation. Walking endurance improvements typically aren't seen until the start of the 6th week of treatment. The client must have enough passive movement of the ankle to make walking possible. There is some evidence that AFOs make more orthotic effects and the functional electrical stimulation has more therapeutic effects. Functional electrical stimulation can be as simple as doing a functional activity during the neuromuscular electrical stimulation, or it could be more complex where EMG data is collected from a slightly contracted muscle to elicit a stimulus, or the therapist controls the delivery of the stimulus. These recommendations are according to NICE guidelines, the National Institute of Health, Care, and Excellence, which were updated in 2021. When I tell you that parameters supported by the evidence suggest that the client is passive, you should consider that when a client does functional activities or repetitive movements during NMES, that you will see even better gains. e-stim should be 5 days a week, at least 18 sessions, or with the use of FES for 20 to 42 weeks for therapeutic and combined effects to support mobility. Electrodes are placed over the perineal nerve and connected to leads in a stimulator unit. If you are using an FES device, the leads should connect to a stimulator unit that is controlled by a switch, such as a foot switch. AFO use during the e-stim is up to the discretion of the physical therapist. Frequency is going to depend if you are just using a straight e-stim/NMES device. Frequency will be between 20 to 60 Hz. With FES, you'd use a lower frequency, like 10 to 20 Hz. If you use a higher pulse frequency, you would likely be using a lower amplitude for FES as compared to NMES, where Hertz can be maybe as high as 100. It's better to stay as low as you can, though, because prolonged high-frequency stimulation can cause a decline in neuromuscular responsiveness. The amplitude for FES will only increase to get a contraction in the movement that you need to accomplish the task versus the NMES, which is passive, where you typically are going to have an amplitude that is as high as they can tolerate because your goal is to generate a contraction that is between 60 to 70% of their maximum voluntary contraction. So overall, amplitude is going to be lower and the pulse frequency will be a little bit lower for FES protocol as compared to what you may have learned for traditional NMES. Protocol for treating plantar flexors, dorsiflexors, and improving gait speed. The outcomes of this intervention have shown increased muscle strength for dorsiflexors and plantar flexors, improved gait speed, improved dynamic balance, and walking endurance. In this study, the NMES device was not specified, but the frequency used was between 50 and 100 Hz. Comparing both frequencies, there was no difference, so I would say it's better to use the lower frequency. The pad placement was on the dorsiflexors and plantar flexors of the paretic leg. The pulse width was 1 millisecond pulses for 100 Hz, or 0.26 microseconds for 50 Hz. The duration pulse time was 4 seconds on and 12 seconds off for 10 minutes. The amplitude intensity was the maximal tolerated intensity. The treatment schedule was 5 days a week for 6 weeks, and the client action, because NMES, was passive. The concurrent treatment was traditional physical therapy treatment between sessions. For plantar flexors, the conventional NMES consists of short-duration pulses over the muscle belly and targets mainly the efferent pathway. The new protocols in the literature from 2020 to present for NMES treatment for plantar flexors have changed directions to apply wide-pulse, high-intensity treatment. This considers the contribution of afferent pathways to sensory motor integration required during gait and balance. Sensory nerves are wider than motor, and wide pulse, high intensity protocols are better at potentiating spinal excitability and reinforce activity dependent plasticity. WPHF has proven effective on improving sensory and motor pathways in the cortical areas of the brain on fMRIs. Wide pulse, high frequency, WPHF, and FES will continue to be seen more commonly in the literature, I believe, for all sorts of protocols. Out of 87 protocols, these were the average parameters for the triceps surae muscle and the tibial nerve. The stimulation site, TS or TN, are both equally effective, although wider pulses of stimulation seem to have a lower metabolic demand from that short pulse, like 0.26 to 0.5 milliseconds. Research has also shown that reflex excitability decreases at a frequency of 20 Hz, does not change at 50 Hz, and spinal excitability changes after 100 Hz. The study didn't give a treatment schedule or treatment duration, so I suggest the parameters that were proposed on the mobility protocol previously. I think 30 minutes because I expect the client will be more vulnerable to fatigue. For the paretic leg, there are no significant changes in general protocols since 2006 to 2007, but one study by Huang et al. In 2022 trialed an approach called CCFES, which stands for Contralaterally Controlled Functional Electrical Stimulation, an improved form of NMES. It was a good study with 60 patients comparing CCFES with NMES. CCFES was better than NMES, but effects on improving the ability to walk, such as walking speed, was no good. I'll show both protocols here. The CCFES was slightly more effective than the NMES overall, though both made clinically significant results. The CCFES group used a device called a DC-1500, which was used to stimulate the tibialis anterior of the paretic side. Before stimulation, the client voluntarily dorsiflexes the non-paretic ankle to a predetermined angle like 15 degrees, which is recorded by a joint ankle sensor, an EMS device. Dorsiflexion of the paretic ankle is elicited from the joint angle sensor when the non-paretic angle moves past the 15 degrees. The stimulation aims to get 15 degrees on the paretic side. The therapist would need to adjust the stimulating intensity needed to elicit that 15 degrees without causing any pain or discomfort. The client only has to relax the paretic leg during this treatment. The non-paretic ankle is held in dorsiflexion for 10 seconds. Have them relax, and when it goes back to 0 degrees, the stimulation ceases. For NMES, the electrical stimulation is placed on the muscle belly of the tibialis anterior on the paretic side. Stimulation intensity should be enough to elicit 15 degrees of dorsiflexion without causing any pain sensation. You do not require the movement of the non-paretic leg into dorsiflexion. Next, I'm going to cover some pelvic floor protocols. These are the most influential works that have given the next protocols. The device studied for pelvic floor training was a Myomed 632, a surface stimulation electrodes which were placed on the bilateral posterior tibial nerve using a frequency of 10 Hz. Increase the amplitude until eliciting a tingling sensation in the foot or you see plantar flexion of the toes. Maintain at a comfortable level. Duration is continuous for 30 minutes. Treatment sessions are 3 times a week for 6 weeks, totaling 18 sessions, or 2 sessions a week with biofeedback sessions. The client is passive during sessions, but should be doing Kegels on their own time. Biofeedback improves outcomes by double. Twice as many people will make improvements in primary outcomes such as fecal incontinence and secondary outcomes of maximal squeezing and anal pressure improvement. Maximal voluntary anal contraction time improvement and overall improvements in patients' assessment of the effect of fecal incontinence on their quality of life. It's important to note that biofeedback alone is twice as effective as NMES, so if you need to choose one, the biofeedback alone will be more effective. But NMES is considered the more conservative treatment, of course. Studies used Myomed 632 equipment. Contraindications include peripheral neuropathy of the lower limbs, skin or soft tissue infection near the site of application, pacemaker, cardiac defibrillator, pregnancy or intention of pregnancy. You should probably also exclude people with type 2 diabetes, metabolic and endocrine disorders, bowel incontinence diagnosis, neural disorders that lead to neurogenic bowel disorder, and overflow fecal incontinence. Neurogenic bladder can affect people with stroke episodes. NMES has been an effective treatment, especially tibial nerve electrostimulation, in reducing the urgency and frequency in men. There hasn't been proven any statistically significant or powerful studies for treating women with stroke. There was a study with 4 subjects, also using tibial nerve stimulation. Another supported intervention is parasacral electrostimulation, which has been proven just as effective as tibial. The only difference was with tibial, clients reported improved sexual function. For tibial NMES, follow all the same pad placements and parameters of pelvic floor training with NMES except for the amplitude, which is set to the client's sensitivity limit. Treatment is scheduled 2 times a week for 6 weeks if giving 30-minute sessions, or 3 times a week if giving 20-minute sessions. Client should also do a Kegel home exercise program daily, follow a toileting schedule, and keep a urinary diary. For parasacral stimulation, position electrodes in the parasacral region on both sides for S3 or cover both S2 and S3 roots, electrodes placed side by side approximately 4 centers apart. Set the current to 10 Hz, but no more than 20. Pulse width doesn't totally matter. It has been proven effective from 200 to 700 microseconds. Patients that have twice weekly sessions make the same gains as those who have 3 sessions a week. Parasacral is an effective approach for overactive bladder, but has limited effects on enuresis and constipation. Neuromuscular electrical stimulation with dysphagia rehabilitation is controversial. Previous research using VitalStim has yielded conflicting results. However, NMES for the stimulation of swallowing has some very promising evidence brought forth. There is conflicting evidence that NMES use alone is effective in treating dysphagia post-stroke. 4 studies were in favor and 1 against from 2001 to 2013. From 2009 to 2017, there were 10 articles that give evidence that NMES as an adjunct is more effective than traditional post-stroke dysphagia therapy alone. For the swallow initiation protocol, the client sits comfortably with the hip and knees flexed at 90 degrees. If you want visual feedback during assessment, the treatment can be done while performing a modified barium swallow study. Stably fix the chair on the standing plane of the imaging device with the radiation tube located on the left side of the patient. Neuromuscular electrical stimulation can be delivered by an NMES device. In this study, they used a YS-1001P electroacupuncture device. Place 1 pad under the suprahyoid group from the lower jaw to the area above the thyroid cartilage, and the back electrode is placed near the C7 spinous process. Adjust the device to a suitable intensity, enough to help stimulate a motor response. Allow the client to acclimate. Then, after 30 seconds, you can perform a swallowing test if it's during an NMES. As stimulation occurs, have the client swallow 3 mouthfuls of mildly thick food. The stimulation period should last no more than 5 minutes. After the stimulation, proceed with the standard video fluoroscopy to observe effects. Improvements have been seen in initiation of the pharyngeal swallow and on oral transit time, while decreasing risk of penetration and aspiration. Concurrent treatment should include oral sensory motor training, necessary diet modification, and if you want to continue with electrostimulation, follow the oropharyngeal or pharyngeal dysfunction protocols, which I'll go over next. Dysfunction protocol, NMES use follows an amp care swallowing and electrostimulation protocol. There is NMES along with 3 to 10 minute swallowing exercises. Pads are placed under the chin, targeting the suprahyoid muscles. Pulse width wasn't specified, so I'd recommend a medium range of 200 to 300 milliseconds. Each exercise was recommended based on evidence related to efficacy of improving swallowing function. Each exercise is chin-to-chest exercise with effortful swallow. Exercise 1 is putting the chin to the chest and swallowing against resistance. Exercise 2 is using the Meadowstone maneuver. Exercise 3 is a jaw opening and closing. Amplitude is given at motor threshold at tolerance. And at the beginning of each exercise, the patient is asked if they can tolerate more intensity. At week 1, the client tries to produce 60 swallows per session during the 5-second stimulus and a 25-second rest. Then pulse-off duration is changed to 20 seconds, aiming for 72 swallow attempts for week 2. In weeks 3 and 4, it's 15-second rest periods, aiming for 90 swallows. This is a gradually increased challenge on the swallowing musculature. The AMP Care electrostimulation protocol also includes a neck postural device that holds the chin to provide the resistance with exercises. Outcomes with NMES and swallowing exercises are more effective than usual rehab care, which can consist of focusing on diet posture, diet modification, weekly speech visits, and home practice regimens. Another protocol uses the same placement but with a TENS unit for 20 minutes a day, 5 days a week, frequency set to 60 Hz. Pulse width is usually 3 choices on a TENS: normal, which is continuous, burst, and modulation, which are types of intermittent with a different length of time for the pulses from on to off. Either during the TENS stimulation or as concurrent treatment, orofacial rehabilitation is included in the treatment. Orofacial rehabilitation includes posture training, reparatory rehab with practice to close the laryngeal straight, dry swallowing practice of oral and pharyngeal phases, and practicing swallows with foods. You can, of course, use this protocol for oral phase dysfunction for someone that has both oral and pharyngeal dysfunction. Oral dysfunction can be abnormality of lip closure, bolus formation, residue in oral cavity, and oral transit time. You can either stimulate both the masseter and suprahyoid group simultaneously, or only the suprahyoid group. The device used was a VitalStim unit. To stimulate both groups, place 2 electrodes on the suprahyoid group on the lateral sides under the chin. Place the other 2 electrode pads on the center of the masseter muscles. Just the suprahyoid, place 4 electrodes on the medial and lateral parts of the group. Pulse width can be set to 300 milliseconds, a low amplitude of 7 milliamps, or until palpable contraction of the masseter muscle. Sessions are twice a day, 5 days a week, for 2 weeks. Clients should also have conventional dysphagia therapy comprising of oral, motor, and sensory stimulation with oral and lingual exercises that focus on strength and endurance to improve the efficacy and safety of swallowing process. NMES has similar effects whether applied to the suprahyoid or infrahyoid, although suprahyoid stimulation shows more reduced penetration aspiration than infrahyoid stimulation. It's also been shown that stimulating both groups at the same time is effective. Here are the protocols for each. For the suprahyoid group, place 2 pair of electrodes on the region between the jaw and the hyoid bone, like in the oral dysfunction protocol previously. For the infrahyoid muscle group, place the 2 pair of electrodes on the region below the hyoid. Each channel can adjust the intensity from 0 to 50 milliamps. Increase slowly at an interval of 0.5 milliamps at a time until the client feels a tolerable stimulation level. This is called a grabbing sensation in their neck muscles. Ask the client to perform effortful swallowing using saliva or a small amount of water during the electrical stimulation. Duration can be set from 1 to 30 seconds on and 1 to 30 seconds off, which you can adjust to show how many swallows you want to complete over the 30-minute period. I'd suggest 5 seconds on and 25 seconds off. Concurrent treatment should be conventional dysphagia therapy consisting of thermal tactile stimulation, various exercises, maneuvers, modified food material, viscosity, and posture. E-stim protocols and recommendations for the upper extremity strongly emphasize the need for participation in functional and repetitive tasks during the stimulation for the best outcomes. I usually tell my patients that a passive intervention is not going to give them active or functional results. Here are the guidelines that I have for you here. The most likely way to get upper arm effects from electrostimulation is with concurrent treatment of functional, repetitive arm movements during the stimulation. The most recent study used a smart arm orthotic device that holds the arm into a position for a linear, singular plane of movement. If you don't get a smart arm, I would suggest that you create some sort of track where the arm is guided to stay linear and the body is set to upright in the sustained posture to prevent maladaptive movement patterns in neuropraxis training. In the smart arm, researchers had set the arm in a mid-pronation and supination position, wrist extension between 0 and 45 degrees to mimic a functional reach-to-grasp position. Then do the repetitive movement. Week 1, do the reaching repetitive tasks for 60 reps. Week 2 to 4, do 80 reps. Training elements that can be progressed are number of repetitions, track elevation or angle elevation, hand position, load, vision and auditory feedback, and amount of instruction and level of supervision. For the NMES, place pads over the triceps brachii, which is the prime mover for achieving elbow flexion. Place one over the triceps brachii motor point and the other over the muscle insertion. If you can't do the NMES in anti-gravity movement because of client physical restrictions, another supported option is e-stim in mental practice. You could use functional electrical stimulation. This is supported by a very small study of 4 clients. Your client must at least have 20 degrees of active shoulder flexion, active internal and external humeral rotation, and elbow flexion along with at least 15 degrees of passive wrist flexion and extension. The client should have palpable muscle contraction at the wrist, 1 out of 5 manual muscle test. The FES study used a device called a Mentomove, which collects EMG activity present during the client's mental practice. It uses 3 surface electrodes, one placed over the targeted muscle to detect electrical signals sent to targeted muscle groups. A computer in the device determines if there is enough activity to meet or exceed the motor threshold, if the client attains the threshold. The Mentomove activates its own biphasic waveform. The call for the hand was from a recent pilot study supporting the use of e-stim along with a dynamic hand orthosis. The orthotic was a SaboFlex device that was custom fitted, which allows active flexion of the MCP and interphalangeal joints with attached springs, creating a passive functional release after grasping. The client should have at least 10 degrees of active wrist or digital movement. Electrostimulation was delivered using an EMPI 300 PV. Surface EMG data was collected using a bipolar parallel bar. In this case, they used the Myometer 4 EMG system that was used to collect outcomes for improvement. You could use one if you'd like to measure Hertz output prior to the course of treatment and during reassessment. The client did repetitive task training with a dynamic orthotic, such as grasping and releasing. Electrostimulation was then provided after the repetitive task training for 15 minutes. It's after because of the neuromuscular fatigue that typically results in hemiplegic muscle with the delivery of constant frequency neuromuscular stimulation patterns. 2 bipolar surface electrodes were applied, one over the extensor muscle group centered over the extensor carpi ulnaris, and the second inactive electrode was placed just proximal to the ulnar styloid at the wrist. The repetitive task training included in the study was grasping 4-inch foam balls that were placed at the midline by the therapist, and the patient transferred them to a low-sided box placed in an arm's distance away, either to the right or the left. 24 balls to both the left and right, alternating, completing as many boxes as possible within the 30 minutes. The client can rest for 2 minutes whenever needed. Be an effective treatment for hands, wrists, and fingers. The frequency doesn't matter. Studies have used 10 to 50 hertz. Also, the responsiveness of axons and neuromuscular junctions tend to decline with prolonged high-frequency stimulation, so best keep it low. Electrodes should be placed on at least 2 innervated areas for best results. Pulse width doesn't matter. Pulse duration should be 1.4 seconds on, 5 seconds, off. Treatments are 40 to 45 minutes. Amplitude doesn't totally matter. It should be at least slightly above motor threshold. If it's preset settings, that may be at a number 4, but somewhere around 3.5 to 3.9 milliamps. Any more than that, you're going to get the same amount of strength in your contraction. It will just be less controlled and likely a lot less comfortable for the client. I usually start low at 1 and turn up until the client reports that they could feel it, then for the motor threshold. 5 days a week for 4 weeks, best effects if it's used continuously while performing repetitive actions. If you have any questions about the protocols covered today, I did put the links to all of the references in the next slides, or you could email me at heather.e.johnson@rm.edu. These are the references used for today's presentation.